Good afternoon, everyone. This is Sharon Byron from TruCode, and I want to welcome everyone to today's webinar, Navigating Outpatient Procedural Coding Changes. We are thrilled that you can join us for what will be a fantastic webinar today. I know most of you are familiar with TruCode at this point, but for those of you who may not be, I wanted to take a moment and introduce ourselves. TruCode develops encoder technology that is used by hundreds of hospitals, consulting firms, and payers. We have a unique approach to coding that enables HIM professionals to quickly and accurately assign codes, and we would love the opportunity to show you TruCode in action at one of our upcoming demonstrations. If you're interested in seeing a demo, you can register for one on our website. There'll also be a link in a follow-up email that will come out after this webinar. Okay, so I would like to introduce you to today's presenter, Karen Scott. Karen is TruCode's Director of Education and Training. She's been an educator for many years, having taught in HIM programs at several universities. She teaches seminars across the country, and she's written several chapters in HIM and coding textbooks. She's worked as an HIM director in an acute care hospital setting, a training director for a national transcription company, and a reimbursement specialist for a regional physicians group. She is past president of both the Tennessee and Arkansas Health Information Management Associations, past chair of the AHIMA Council on Certification, and a past director on the AHIMA Board of Directors. So before I hand it over to Karen, I would like to review a few housekeeping items to make sure everyone has a successful webinar. First, all attendees are in listen-only mode, so that means you need to use your control panel to communicate. This is the panel on the right-hand side of your screen. You can minimize it to see the screen better. You can drag it around, collapse it, expand it by clicking on the little red box with the arrow. If you'd like to ask a question, there's a question section within the panel. That's towards the bottom. And to ask a question, just click on the plus button. It will open up a text box. You can submit your question at any time during the webinar. We will try to answer your questions at the end, so feel free to send them in, and if we don't get to them, we'll be happy to follow up in an email. I also want to point out there are handouts for today's presentation. Those can be downloaded under the handouts section. They were also emailed to you in a reminder that went out earlier today, so hopefully you had a chance to see those. And finally, we want to make sure you receive your CEUs. So tomorrow morning, we'll be sending out an email to all attendees, and that will contain a link to a brief webinar evaluation. I should note this email will be sent to everyone that is attending this live webinar. For those that are viewing the webinar as a recording on demand, there are separate instructions at the end of this webinar that you'll need to follow to get your certificate. But once you get that evaluation, just submit it and you'll be able to download your certificate from there. If you have any questions or any problems, you can always send me an email and I'll be happy to help you get what you need. And you can respond to any of the webinar emails. Those will come directly to me. All right, with that, I'm going to hand it over to Karen. Thanks, everyone.
Thanks, Sharon, and welcome everybody. We're happy to be with you today. We're happy that it's finally December. It's the last month of the year, so we're almost to the end of 2020. And again, it's been a busy year for all of us, especially with all of the COVID codes and everything else. And that has made some changes in the code book. So what I'm going to cover today is I have given you in your handouts today, I've tried to prepare all the different changes. And the way that I do go about getting ready for these is I do get the paper code books at the beginning. I like all the color coding and things. Of course, we here at TruCode are working on our TruCode version, basically of getting everything out so everybody will have that by the end of the month. But basically, I go through every single page of the CPT code books. I do go through and look through and try to read everything and see exactly what they're doing. I also use the book that the AMA publishes that is CPT Changes and Insider's View. I'll give you those references again at the end. And so I do go through all of those and I try to look at all the different areas and reasons why they made the changes for that particular year. Please remember that all CPT codes, all code descriptions, everything is copyrighted copyright protected. So all of our discussion examples are just for educational purposes only, but you do want to refer back to the official, which is the CPT code book or the AMA's website, to be able to get any absolute information and advice from the source, which is from the AMA. So just wanted to make sure we talked about that a little bit. And we're going to talk too about the fact that a lot of the changes are not in, if you've got the paper book, they're not in the book at the very beginning. They actually printed these months ago. And so there've been a lot of changes, especially with all the COVID codes. And I know it's definitely been keeping our product team very, very busy here at TruCode, getting all those codes in, and we do get those out to you as quickly as possible. So when you get if you are a TruCode customer, when you get all of the code changes and all of the updates at the end of this month, which typically we'll have out before the holidays, then it will have any other changes with their appropriate dates that they are effective. So you don't have to wait for the paper book, which makes it awesome as well. So we'll talk about the CPT changes by book section. Again, we'll talk about rationale and some examples, and we'll go through any guidelines and note changes also. Because we have all of the changes in your packet today, I'm not going to go through every single slide that you'll see today. Just I'm going to keep a good watch on time and make sure that we can get through the major stuff. We are probably not going to spend a lot of time with like radiology and path and lab, for example, just again because of the limitations of this presentation today. So, but you have all the changes there in your handouts if you need them. So let's go ahead and move forward. So here is a review of or an overview of the changes for this year. We have approximately 329 changes. So again, not as much as we see some years, but still in every different area. So within the actual new codes, now this does not take into account all of the different guidelines that are changed this year. That's really a big part of these changes. So sometimes you look at the number of codes and you go, wow, there's not much there. But like with E&M, there's only 2 E&M codes that are new this year, 17 revised, 1 deleted code, but they totally renovated all the office visit codes. So that's a huge deal for our clinicians that are trying to use those codes. So we'll talk about those again as we go through. In anesthesia, no changes this year at all, so no big deal there. In our surgery section, as far as the actual code numbers, we see 11 new codes, 28 revised codes, and 11 deleted codes as well. In radiology, only 2 new codes, 6 revised and 2 deleted. Path lab, we see quite a few. Again, a lot of those are really because of those proprietary lab codes that are found at the back part of the book. And again, I have those for you in the handouts, but really in the main part of the pathology and lab section, not a whole lot of changes. Only 9 revised codes and then 1 deleted code in that area. In the medicine, which is kind of that hodgepodge at the back of the book, there's 18 new codes there, 4 revised codes and 9 deleted codes. Our category 2, for anyone that does use the category 2 codes that end in the F's for your risk adjustment, any of those kind of areas there, quality measures, there was only 1 revised code there. And in category 3, we did see 85 new codes, 69 revised codes, and 54 deleted codes. Remember, a lot of the deleted codes are not actually deleted. They actually are going to be deleted back here because they have found that they are good enough to move to the front of the book in the category 1, which is the main part of the book. And so they don't actually go away. However, I did see quite a few of those codes this year that were they were archived. Remember, they only keep the category 3 codes in the book itself for up to 5 years, and then if they're not being used, they kind of put them on a shelf there. So again, just wanted to make sure you know about that if we don't have time to get through all those codes today. So let's get started with the actual codes. So at the very beginning of the coding area is the introduction. That's also a really great place. If I have someone who's brand new to coding, always have them go and review the introduction because that has all the information about all the symbols and everything else about how the codes are set up. One of the big things this year is just a reminder that the codes are going to be released more often than just annually. So it's not enough just to have the code books. Again, that is why it's helpful to have like an encoder like TruCode does provide for you, because we can get those new codes out to you as much as possible. I know this past year we have been crazy busy trying to keep up with all of the codes, mostly CPT codes for the different lab tests. And every time they come up with a new test, and now with all the coming of the vaccines, those are going to be coming up soon as well. And so basically within the beginning of the book, they do give us a code set update calendar and talk about, for example, category 1 codes. Remember, category 1 codes are the main codes in the main part part of the book. Category 1 codes, Category 2 codes, the timeline release is August 31st. Effective timeline is going to be for every January 1st. So most of the codes will still become effective on that January time frame. Category 3 codes, however, have 2 times, basically January and July for those. And then with a lot of our path lab, there's actually several times throughout the year, 3 times. And then also the proprietary lab, there's actually 4 times. So those are going to be updated more frequently. And I've actually given you the website at the back of this presentation that you can actually get on the AMA's email list, and they'll let you know when there's ever new codes coming out or any kind of updates to the system. If there's a mistake in the book or anything like that, you'll get those. So I'll give you that information as well. So they do go through and give us some information about those release and effective dates. Now, of course, as always, remember that the resequencing continues. The codes are not always in the same numeric order, but there is that little hashtag or number sign or tic-tac-toe sign, whatever you would like to know it as. Basically, when you see that sign or symbol next to the code, you'll know it's not in its correct order. This year, there were no changes in the modifiers, and the only thing as far as appendices, there are new examples in Appendix C. However, I did hear about yesterday that they are having a new appendix they're going to be putting together that you can see actually out on their website, and it's Appendix Q. And Appendix Q, from what I understand, Appendix Q is going to be a list of all the COVID codes. They're going to put them all together in one time. Of course, that is not in your paper code book, as you will, but still, those are out there. Now, within the evaluation and management section, the very beginning of your code book, the guidelines are quite a bit longer. They really did an overhaul because of the changes to the evaluation and management code guidelines. So the codes didn't really change, but the guidelines have changed for office visits this year. We have 2 sets of guidelines. You have the guidelines for office visits, and then you have the guidelines for all the other codes. So we have those. They also reorganized them, anything that was common for all the codes, and some definitions are different, like time for some of the existing codes is still going to be based on the amount of counseling time, but with office visits, time is the total time that is spent on the whole entire visit for that day. So the new guidelines for office visits, they have deleted out code 99201. They're new guidelines specific to the office visits. Remember, those are office/outpatient visits. They did change in the component scoring for those new and established excuse me, office visit codes. They made changes to the medical decision-making table, and then of course changes to the typical times associated. So I'm not going to spend a lot of time, again, just because of our time frame. We could do a whole half a day or a whole day just on how are you going to assign the new E&M codes or the E&M codes based on the new guidelines for these office visits. But I'm just going to briefly go through that today because that's only one thing that has changed, but probably the most significant change there. So with your office visit codes, you're going to make, you no longer have to worry about history and physical and medical decision making. It's only going to be based on medical decision making or the total amount of time for those services performed on the date of the encounter. So time has gone with these codes from being implicit to explicit. In other words, in the previous systems, you have had with your office visit codes, it'll say things like the doctor spends 20 minutes with this patient typically. That's just really an implied time. But now what we're looking at is with the codes when you use time as the way to be able to assign these codes. It talks about the entire time that you spent with the patient for that day. So like, for example, with code 99214, it now says when using time for code selection, 30 to 39 minutes of total time is spent on the date of the encounter. And so basically that's going to be a little bit different than the other codes. Now you still will use the existing guidelines for all other E&M codes. So that's your emergency department, that's your preventive care, all of the other, everything else in the E&M section is still going to be used the same way. So with these office visits, if you do choose to use total time as the way of being able to assign these codes, that is going to be the total amount of time spent on the date of the encounter. That would include both face-to-face and non-face-to-face included, not time by the clinical staff. But when you're looking at it from a physician perspective, the time would include everything you see there, as long as they're not separately reported. So it's all the time spent, not just in the time when the doctor is seeing the patient in their office, the face-to-face, but all the other times, the preparation, preparation, getting ready for that visit, as well as the documentation. If they have to coordinate care that's not separately reported, all of that would be included in the total time there. And here you can see just a breakdown of the time required. Remember, they did delete out 99201 because since we're not using history and physical anymore, then you are not going to have, there's not a difference. So basically there's really 4 codes for physicians, there's 4 codes for your new patient, and really there's 4 codes for your established patient because the 99211 is more for a nurse visit. But you can see there's the total amount of time. There's also a new prolonged services code, and that's at 99417, and that is only going to be used with the highest level, only when you're using time as the factor of deciding on the actual code. And so basically that is a new code, and we'll talk about more about that in a few minutes. If you choose to use medical decision making, one of the nice things about that is that they are the same 4 complexities. Straightforward is the lowest level of medical decision making, low complexity, moderate, or high. You still have the 3 different elements, which basically are going to be the problems, the data, and then the risk to the patient. You still have to have at least 2 out of those 3 required to get a level. You're looking at the highest 2 scoring elements. But again, remember, we're not looking at history and physical. Those are no longer key elements in deciding the code for your office visits. All right, so there are definitions. The AMA has gone to great lengths to provide us with very detailed definitions so we can all make sure we're speaking the same language. Lots of definitions there. You want to be aware of those. What are you counting as far as the first area, which is your problems? You're going to count any diagnoses that impact the care today. You can go with the MEAT acronym, which basically is, did you monitor that problem? Did you evaluate it? Did you assess or did you treat it? As long as it does require or provide additional risk, if it's addressed, if it's managed, then certainly you would count that in your number of diagnoses, or and we're not even calling it diagnosis anymore, we're calling it the problems evaluated for that particular service. So here is the listing there. So remember I said minimal, low, moderate, or high, and you can see and these are all defined for you, like what is a stable chronic illness versus a chronic illness with an exacerbation. So those definitions become super important if you're educating your clinicians on those. In data, you have 4 levels as well, and those do fall into different categories. So like, for example, with your limited, which is the second level of your data, then you're looking at category 1, which is a combination of tests and documents, or assessment requiring an independent historian. With a moderate level of the data, you're looking at these 3 categories again, and you have to meet certain criteria. Like it says, at least 1 out of the 3 categories. Category 1 would include any combination of 3 from the following, or category 2, independent interpretation, or category 3, discussion of management. And again, all of these terms are defined for us. Extensive, same thing as moderate, except you have to have 2 out of these 3 categories to be able to determine the level of data. The last one is going to be our risk level. And with risk level, there's not as many definitions, although they do define risk and morbidity and things like that. And they talk about social determinants of health. But you can see they don't actually give you any kind of examples in a straightforward or minimal or low risk of morbidity. But they do start giving examples, which look pretty common to what we did last year, like prescription drug management or making decisions based on surgery, or also if the diagnosis or treatment is significantly limited by the social determinants of health. That's become a much bigger deal. We need to make sure we're coding those correctly. The ICD-10 codes for those, and if they do impact the care, we definitely want to make sure you're coding that, because that can get you to a level of moderate risk. And then high, you can see high level of risk is things like decision made regarding elective surgery, decision regarding hospitalization, decision made not to resuscitate. It doesn't say you had to do those things. It just says you had to make a decision about those particular things. And then when you put them all together, this is just an example of the elements of medical decision making. And you can see that there's exact same requirements for both a new patient versus an established patient. So like, for example, in the straightforward, it's a 99202 if it's a new patient, 99212 if it's an established patient. So it does kind of streamline it. It makes it make more sense. It's cleaner, it's clearer. I think it's going to be a lot easier for our clinicians to use. Now, if you are assigning E&Ms for your hospital, remember you can still go with Medicare. Instead of having to follow these guidelines, you can go with, again, if you have a template that you've created for your facility, then you can use that, or you might find that this works good as well. So again, that's a little bit different from what the code book is looking at here. So that is the biggest thing, biggest change of everything we have in these guidelines and all of the information for this year. Now, what else went on in the E&M changes? As I mentioned, we have the prolonged services code. We have some that are direct patient contact or without direct patient contact. There are codes for an additional 30 minutes. And then as we talked about, there is the new code for use with the highest level of office visits, and that's for each additional 15 minutes. So very specific. And there is a nice little table that they've added into the code book so you can compare which codes are appropriate if you are needing to use prolonged services code. Typically, again, this would be for our physicians or professional fee, pro fee billing for that. There are more guidelines with preventive care. They did add more information when you have a well visit that turns into a sick visit. So there's some good information there. No changes in the preventive services code, but there is information on when you can code those together and using modifier 25 with those. And toward the back of the E&M section with remote monitoring, they did revise some of the notes and the time calculations. And a lot of the notes changed because remember, they deleted out the 99201. So we have quite a few codes that simply the paragraphs are changed simply because of the fact that they had to if they have a listing that says don't use this code with these or use this with this one, if there is a code that was changed, they have to change the whole paragraph. So that's really where a lot of the changes that you see in the back part of the E&M section are really for that. They did come up within our care management, our chronic care, better definitions, easier to understand the way that these are worded. And these are going to be for your really, most of it's non-face-to-face, but a little face-to-face for when your doctors are spending time basically coordinating care. When you've got people that have 2 or more chronic illnesses where they're not actually seeing the patient necessarily, but they have to do a lot of work to arrange things like home health or whatever other types of things need to go on that. So they did give us another new code. Now, when you see in my handout today, when you see like an X at the beginning, it's just because the codes are copyright protected by the AMA. So I try to be careful not to actually put too many of their copyrighted codes into my presentation, just to make sure I'm respectful of that. But when you see an X at the beginning, like here, because we're in the 9,000 level at the beginning, the E&M codes, they all start with a 9. So that would actually be 99439 if you're not as familiar with the way that I do that in my particular system. So again, it's a way to help us focus on where the codes are, but again, still be respectful of the wording and everything that belongs to the AMA. So again, with your advanced care planning, that just watch the list of codes that can be built together. And again, a lot of that was also because of the deletion of the 99201. And then the general behavioral health, they did revise some descriptions and instructions in that area. So not too much of a change there, but some areas there. So we're going to move on now to the surgery section. Let's take a look at those. And I'm going to simply flip that to, I've got, again, my paper code book here so that I can point you in the right direction when you have time after this presentation to go through and actually review. You can just jot down the surgery section starts on page 89 if you have the professional edition of CPT for 2021. And so as we go through with the fine needle aspiration, basically they did under the F&A codes, they just basically gave us some guidelines on page 90 where it does talk about other types of biopsies other than fine needle. Remember that if it's a fine needle, the doctor actually has to say the word fine needle. It is a gauge of the needle, but again, we don't, from a coding perspective, have to know what that gauge is. If the doctor calls it a fine needle aspiration, then you code it in the F&A section, which is at the very beginning of the surgery section. But remember, there are many other types of needle biopsy codes that are not coded here. And there's just a note to remind us because of a deleted code back over in the 3000 level here. There's some really great pictures. One of the things I like to use the CPT book for references is because they have a lot of great pictures, and they've done better these last couple of years about, instead of these being black and white pictures, they're very nicely done colored pictures, like on page 95, great pictures of the different tangential biopsies of the skin and punch biopsies. And I like that because it helps me understand the procedures and how they're used. Now, the next thing we want to go over to is looking at code 11960. Again, you can see that would be 11960 because we're in the integumentary system of the book. So as we get to 11960, let me just flip in my book. This is page 102 in the professional edition of CPT. Basically, you'll see that there were a couple of revised codes in this area here, right under code 11960. It just tells you what to code it with or what you can't report it with. And then also, because we have these definitions here, we're going to look more at the breast reconstruction codes in a moment, but they just modified and modernized a lot of the information with our breast procedures. And so they started it here, like for example, 11970 used to say replacement of tissue expander with permanent prosthesis. Well, it's really more of an implant than a prosthesis. And so they just changed the terminology to better meet modern technology and modern medicine, the way that it's worded there. So basically just some good notes. Those do not report notes, super important to make sure that we're coding those appropriately there. With the breast repair and that area, the last part, back part of your integumentary section of the book, let me just flip there to give you a page number for those. And those are back over starting on page 123, page 123, 124. This is where under repair and or reconstruction, they talk a little bit more about breast reconstruction, when it can be used. Again, just try to modernize the wording. You'll see a lot of revised codes on page 125, and these are all like breast reduction, breast augmentation. And again, they just went through the wording here and made sure that it made sense for modern terminology here. So like, for example, 19318 did say mammoplasty, but instead now it says breast reduction. Just makes more sense there. Or 19325, it says breast augmentation with implant. It did say mammoplasty augmentation with prosthesis. So you'll notice the word implant, which makes more sense, as well as instead of mammoplasty, they use the word breast there. So just kind of cleaned it up a little bit there. You also see with code 19361, breast reconstruction with latissimus dorsi flap. That is the parent code, and that is why the codes from 19364 through 19370, 19364 through 19369, those codes on page 126, those are now children. So we have the family approach in CPT. If there is any consistent information, it makes more sense to put the consistent information in the parent code, like in this case 19361 is the parent code, and that breast reconstruction is also inherent in the codes that we call the children code, which is 19364, 67, and 68 and 69. So all of that, and again, just clean those up a little bit to make sure that the terminology matches what is being used now. Going to the next one, and that is in the musculoskeletal. Not a whole lot of changes in the musculoskeletal section this year, but the changes are actually back toward the back in the endoscopy section, and that's page 205 in the book, 205 in the professional edition. And they just talk about the need to code separately if they're doing an arthroscopy in the knee and there is a loose body. So basically, if you're already in there doing the procedure and there's a loose body, something floating around down there that's sticking out there and you just don't need it, typically it's not any additional work to remove that loose body. But sometimes there may be, if they're in there with the cannula and that loose body is too large and they have to do something more, then you are able to code it. So they're just very specific about that. It now says that you can use those codes also only when the loose bodies or foreign bodies is equal to or larger than the diameter of the arthroscopic cannula used for the specific procedure, and can only be removed through a cannula larger than that used for the specific procedure, or through a separate incision, or through a portal that has been enlarged to allow removal of loose or foreign bodies. So there's great codes for those, but they're just trying to make sure that we're not using those codes inappropriately, that if it's extra work, it's only because you had to move that cannula out of the way and put a bigger one in, or you had to make a separate incision, or you had to again, with the scopes here, you had to enlarge the portal to be able to get that loose body out of there. So again, very extensive, not the codes here, but the definitions and when you can use them, instructions, very important with your arthroscopic removal of loose bodies or foreign bodies. The other thing in that section is with code 29822 and 29823, this is where we have using an arthroscopic procedure, they're doing debridement. And the codes did just say debridement limited or debridement extensive. What they did this year is really nice. They actually said, what do you mean by limited? And what do you mean by debridement extensive? So for example, with 29822, it says now with limited, that's one or two discrete structures like the humeral bone, the humeral articular cartilage, and so forth. So it gives you more information. And then with an extensive debridement, it says three or more discrete structures, and then gives you an example of what they mean by discrete structures. So again, better information, so we're all using these codes accurately. We're going to go from there into the respiratory section. I keep checking my time, and I think we're just doing really good with this. So with our respiratory section, just a couple of things there. Toward the beginning, in the nasal procedures, they did add a new code, and this is on page 214, and it's code 30468. So once again, you can see that X would turn into a 3, so that's 30468 is a new code for the repair of a collapse of a nasal valve. So basically with that code, it just says repair of nasal valve collapse with subcutaneous or submucosal lateral wall implant or implants. Remember, when you see the S in parentheses, that means whether you had 1 implant or 5, it's not going to be coded separately. So basically, they're using those implants to support the cartilage. Those implants are made up of absorbable material, either put in right underneath the skin or right underneath the mucosa, usually in the lateral wall there, and they're going to use that to support the cartilage. And again, it is done through the percutaneous methodology there, and it's great because it is more minimally invasive. We do see typically with these kind of procedures, you have to have the person in an operating room. This could be done in a lesser type of area. And again, also one important thing there is that this code is inherently bilateral, even though it does not say it in the code itself. But as you look at the notes underneath the code, it says this code is used to report a bilateral procedure. For unilateral procedure, use modifier 52. So definitely important in this area to look for notes because again, it doesn't say in the code itself, the description, that it's bilateral, but it is inherently bilateral like the other codes in this area. Those would be great test questions if I was making up a national exam. I don't have to do that anymore. But again, those are the kind of things where you've got to be super careful with in CPT to make sure that you're using the modifiers appropriately there. Now, the next thing we go to, and again, not a whole lot in this section, but we're going to go over to the lungs and the pleura. And in this particular area, let's look at code 32408. 32408. That should get us to the right section. Actually, you can start on page 224. Page 224 under lungs and pleura. That is when they talk about doing pleural or lung biopsies or diagnostic wedge resections and what codes you should use for those. So good information there on those particular codes. And then when you look at the code on page 226, it talks about the core needle biopsies. Remember, we talked about the fine needle biopsies, FNA, fine needle aspiration, fine needle biopsy that are back there. But remember, I told you that the note was changed at the beginning of the surgery section because of this new code 32408, which is a core needle biopsy, lung or mediastinum, percutaneous, includes image guidance when performed. So that's the important one there. It includes imaging, and because basically it does in the information there, this is meant to be done once per lesion, not per biopsy, basically. And so as you see, there's other information there that can support that, but that is the intent of that code, basically, is to use that once per lesion. Now from there, we go over to the cardiovascular section. And again, didn't see a whole lot of changes in this area, but I do want to start at the very beginning of the cardiovascular when you have your pacemakers. Now the pacemaker area has a great table. This table is found on page 244 in the professional edition of CPT. And it does show you about halfway down there, it's got a listing that says removable pulse generator with replacement pulse generator only. And basically, if you look at the categories, it's got code 33227 and 33262. So that's the removal of pulse generator. Actually, that is this is green in the book because they had to change it because of the fact that they just, remember, we do have a new category 3 code, which is going to be your 6147T, 0614T. 0614T. And so because of that, they just changed the wording here. So they just added in the word applies to, where it talks about only single lead system. It applies to transvenous or subcutaneous defibrillator lead systems because of some of these new category 3 codes back in the back part of our book there. Okay, so that's the only real thing there. Again, we do have quite a few notices throughout the code book. Whenever there are codes that should be assigned with the category 3 codes, look underneath the codes themselves and make sure that you are following those. If it says, for example, under code 33262, and I'm on page 248 in the book, 33262, there's a note that says for removal and replacement of a substernal implantable pulse generator, use 0614T. So that's where it is referred to within the body of the category 1 code. So always look for those notes because you might need to be using a category 3 code appropriately instead of using a category 1 code, or even trying to use an unlisted or making a modifier fit in there. So just want to help you with that. All right, the next thing we're going to look at is going to be over at the page 251, and on page 251, that's the heart and great vessels, and they just talk a little bit here about patients who do have cardiac procedures. They may require cardiopulmonary bypass, and so most of the services do include cardiopulmonary bypass. It's part of it, you know, like with the cabbage. Definitely with their got a cabbage, most of the time with a cabbage, they're going to do the bypass as well. So many times it's included within the codes themselves. However, we are seeing more procedures like the valve replacement, that kind of stuff, where they can do these with a beating heart. And so you don't always necessarily do things open anymore, and we don't always have to have cardiopulmonary bypass. So in those cases, you are going to need the additional code. So there's a note on page 251 that just says cardiopulmonary bypass is distinct from support of cardiac output using devices, and it tells you where to go for the cardiac assist devices. So just watch those carefully. And then there's also a note on page 253, and that is with the aortic valves and the procedures, which are the transcatheter aortic valve replacement or transcatheter aortic valve implantation. And lots of good notes there about those, but it does tell you that if the patient needs transcatheter ventricular support is required, then it does say you should go ahead and use the ventricular assist devices. And we saw some changes there as well, and that's why this note is changed, because of we have some new shunting procedures that can be done at the same time. So there's several notes in this area that lead you to these new codes there. Now we move over to page 257, which is the venous grafting only for coronary artery bypass. And it just reminds you, and this is right above code 33510, which is our vein only. It does remind us that the procurement of the saphenous vein is included and should not be reported separate. But when they do other types of vein or sometimes artery procurement, then you can code them separately. So again, the saphenous vein, because it is very minor, it's not, it's very superficial, that is included as part of it. So it's included already in the work value. So just make sure if there's any other types of vessels that are harvested, you want to make sure you code those separately. So be careful. Things like fempop or the upper extremity. All right, and then let's go ahead and move over to the new shunting procedures. And the new shunting procedures are over on page 262 and 263 in our professional code book. And those procedures the new ones are from 33741 through 33746. And these are transcatheter procedures, and these are shunting procedures. So these typically may be done together, maybe separately. from other procedures there, but basically they explain them here about what's included, what else you can code with them. And basically what these are is typically either an atrial septostomy or the intracardiac shunt. And then you have the add-on code for each additional shunt location. So again, that's read the note very carefully, read the description very carefully, because it says like 33745 is the initial intracardiac shunt, where 33746 is the add-on code, and that's for each additional intracardiac shunt location. So it's a location, not the number of shunts, but the shunt location. So again, you want to be careful with those. But basically, these are used most commonly for congenital heart defects to improve the blood flow in the heart. And again, there's information there about when you can also code the cardiac caths and injections at the same procedure. So there's lots of code also and do not report and modifiers and things like that. So just review those notes if you do any cardiovascular surgery coding. With our cardiac assist, which we mentioned a few minutes ago, let's go over and look, and this is at 33927, page 267. 267 is the page number, and this is under your heart-lung transplant area. It just reminds you under the implantation of a total replacement heart system, it says for implantation of ventricular assist device C, so it leads you to the codes for that information. And we did have a new code this year, and that new code is 33995. So let's go look at that 33995 code, which is found over on page 273 in the professional edition of CPT. And that is the insertion of a ventricular assist device percutaneous. It includes all your radiology, supervision, and interpretation, and it is right heart, venous access only. Then the revised code underneath that is left heart, atrial access only, and then you have left heart, both arterial and venous access with a transeptal puncture. And then 33992 is revised for the removal of the percutaneous left heart ventricular assist device, arterial and venous cannula. So it depends on the cannula there. So again, you do have these revised codes because they're divided into what side on, and if it's venous access or arterial access. So that makes a difference in these code assistance there. There is another new code in that area, in the same area, 33997. 33997. Notice I just said new code 97 there. That's 33997 because we're in that same area, 33997, and that is a removal of a percutaneous right heart ventricular assist device venous cannula at separate and distinct session from insertion. Okay, and then there's a note about what to do if they remove a left or right one during an open approach. It tells you where to go for that one. And then the last one there is 33993. 33993 is a repositioning of a percutaneous right or left heart ventricular assist device with image guidance at separate and distinct sessions from insertion. So you can code the removal, you can code the repositioning if it's at a different session than from when they put them in. Under the venipuncture codes, which let's go over to 36450, 36450, that's several pages back. So I'm going to flip my pages. You're probably hearing me flip the pages here the old-fashioned way. 36450. The only problem with that is sometimes when they're out of order, it's harder for me to find them. 36450. It's on page 297 in my code book, and it's under the code is for exchange transfusion blood newborn, and it just reminds you if they do a manual red cell exchange, there's new codes, and also an automated red cell exchange, new codes there. And basically those are going to be codes for a removal of the red blood cells, either by, like I said, automated or by the phlebotomy and then transfusion. So that is an exchange. Again, it's underneath that exchange of the newborn with those codes, 36450, 36455, and 36456. All right, so just a reminder about when you're going to use those codes. And again, that's typically done for therapeutic apheresis. Now, the next place we want to go is a couple pages back. So I've got a page number here for you, just so I can keep myself in line here. So page 321 is the next place I'm going to go, page 321. And that is going to be over still in the cardiovascular system, but we're in the codes over at the vascular intervention codes there. And on page 321, just underneath code 37239, there is a note that talks about using these codes or do not report them in conjunction with 0620T within the tibial peroneal segment. So again, very specifically about when to use these codes. Sometimes with category 3 codes, you can use them together. Sometimes it's one or the other. So you just really have to watch those notes and guidance and review the articles and make sure that you're coding those appropriately. And that's one of the great things about with TruCode. You've got the articles, there'll be a lot of codes, articles in the CPT Assistant publication, and it'll be right there for you as you're trying to code and making sure you know where those all are going. So now we're going over to the digestive system, which has a side stripe on the page this year of a pretty purple, deep purple color for our 40,000 level codes. Just a couple of things here. One note under code 47537. So let's go over again. That's pretty far back. 47537. Let me find that real quick there. 47537 is found on page 381 there, and that is a removal of the biliary drainage catheter. What you want to see underneath it, it's got a note that says for removal of the biliary drainage catheter not requiring fluoroscopic guidance, well, then you just need to use your E&M code. And mostly that was changed because, remember, we don't have the 99201 code anymore, so the note itself is really not new. It's just the fact that whenever they delete out a code, anywhere it's mentioned, anywhere in the book, they have to go back and review that particular note. It is nice when they do kind of remind us about what those notes say, because I think sometimes when you're looking at the book, everything's all one color. When you see those green, anything that's new is green, and so it kind of pops. You can review it very quickly. Again, some really nice pictures. There's a picture on page 380 of the percutaneous biliary stent and drain placement. Super nice, and you'll see theirs as well. The only other thing there is a deleted code, and this would have been over at 49220. And what we saw this year is that they did delete out some codes, and I tried to add those in because I want to know what happens to these codes. Why did they delete those codes? And in this particular case, they deleted a code out. It was a staging laparotomy for Hodgkin's disease, and they just don't use it anymore. So we saw several codes that were deleted just because of low utilization. In the urinary system, we only had one change this year, and it's not even a code number. It's just the actual a note underneath code, and this is going to be over in your urinary. That's going to be 50690. Let me find that for us real quick. 50690, and that's on page 404 in the code book. And that's an injection procedure for visualization of the ileoconduit. And it just reminds us, because that one says exclusive of radiological services, it just reminds us that you can code, if you are, part of your job is to code the radiology portion, you can code the code for the radiology supervision and interpretation. So it just leaves us there in the right location. One new code in the male reproductive system, and that's going to be at 55880, 55880. Let me give you a page number for that one in the male. And I think I just jumped past that to my female reproductive. So let me find that one, 55880. And that is on page, oh, here it is, page 425 in the book. Brand new code 55880. Again, that's 55880. And that is for underneath the codes, other procedures. It's ablation of malignant prostate tissue, transrectal, using a high intensity focused ultrasound. And it does include the ultrasound guidance, so you can't code that separately. But notice that we've started to see more codes where you have different codes for benign procedures, as opposed to when it is malignant or cancerous. Now, this is one of those codes that I believe was a category 3 code last year, and they moved it over into the main part of the book because we saw a couple of those places where if it was benign diagnoses, it was coded here. If it was malignant, it was over there. But it's being used frequently enough now that they decided it needed to be here in the main part of the book. A couple of things in the female reproductive system, they did delete the code, and this is going to be at 57112 for a complete vaginectomy, just again because of low usage. There are some new codes under a couple of codes leading to a new mapping code. Let's look at this new mapping code, and that is 57465. 57465, and that's an add-on code they added on page 433 in the book. Again, add-on code 57465, and that is for computer-aided mapping of the cervix uteri during a colposcopy. And basically that is used to identify abnormalities to come back and do a biopsy later. So if they can see anything going on there, they can map it to be able to show exactly where they need to go back to or when they're doing biopsies there. One more deleted code in this area, vaginal hysterectomy greater than 250 grams with fixation. Again, there's other codes that have the same kind of terminology, but this one was used very limitedly, so they just took it out. And then with maternity care, they just reminded us with maternity care, because it is a package concept, the time when the person comes in to get a confirmation, or if it's at a different visit where they're just doing, maybe the patient comes in and they're sick a lot and they do a pregnancy test and say, oh my gosh, you're pregnant. That doesn't start the actual package. You don't start the package of pregnancy care until the person comes in for their initial history, where they do the history and physical, not confirming the pregnancy, but when they first, okay, now you're pregnant, what are we going to do next? That kind of thing. Excuse me. So that's all we got there. And then also in that same area, when you've got like abortions, which is going to be basically whether it's a miscarriage. If it is a medical treatment of a miscarriage, then you are only going to use an E&M code. You would not code it up here. And again, most of the changes there are because of that deleted out E&M code, so really not a big deal there. And then the last section of surgery really is going to be your nervous section. Again, not a whole lot here. You see 3 deleted codes: craniectomy, excuse me, to implant electrodes, neuroendoscopy, intracranial with retrieval of foreign body, and then also a laminectomy, cervical. Those codes, there's actually 4 codes on this page that were deleted for this year. Again, all of those because they just weren't used very much, so they just got rid of them, and then we can use them later if we need to. There are some revised codes over. Let's look at 64455, 64455. And these are over on page 475 in your code book. 64455 is underneath the introduction of an agent and the somatic nerves. And this is where you've got the plantar common digital nerves, or Morton neuroma. And basically, these are all now child codes. Remember, we talk about a family of nerve blocks. These, instead of standing on their own as individual codes, the common information is now found in the parent code. And these all look like they're missing information in the definition, but it's basically because they are now child codes in the family. So shouldn't really hurt you too much. Just want to make sure you know why that is the triangles there. And then if you go over to page 482, page 482, this is going to be codes, and again, this is just information. The codes didn't change, but like, for example, underneath code 64714, this is neuroplasty lumbar plexus. It just reminds us that we should not use this in conjunction with the tissue expander codes, that 11960. If you remember from the very first thing we talked about in this hour in the surgery section, we basically then just reminding us about, hey, don't use these codes in conjunction with those tissue expander codes. And then you can see also under code 64721, it says for endoscopic procedure use, and it gives you another code. This did say arthroscopic, so they just endoscopic, just changed some terminology around there. I don't know that that's going to impact your coding very much. And then no changes in the eye section. We did have just a couple of things in the ear. Again, most of these are because of the fact that any note that had the deleted 99201 code in it. They did also delete a code, revision mastoidectomy with apicectomy, excuse me. And then also a couple of new codes we probably want to glance at, and that is over at 69705. Let's take a look at 69705. It's a short section here. 69705, page 506. 69705 is a nasopharyngoscopy, surgical with dilation of the eustachian tube, unilateral, and then 69706 is also in that same family. The parent is the 69705 that contains the common information, and really the only difference is the first code is unilateral, the second code is bilateral. So that's all we got there as well. So again, watch your do not report notes, and typically those are used to treat either obstructive dysfunction or some kind of trauma in that area. And again, these are done with dilation, not surgical like you'd see open procedures. These are in a different spot because of that. All right, so I'm looking at my time frame, and it looks like that's probably about all the time we have. Those are the main changes. I'm going to quickly go through. You can see not a lot of changes in the radiology section, a couple of things there in the heart. In the diagnostic ultrasound, mostly just notes referring us to category 3 codes there. Just watch a lot of category 3 codes. Nuclear medicine, again, just some revised codes there, not very much going on. In pathology, we didn't see a whole lot. Again, with molecular pathology, those are more of our genetic type things. They do add those codes in every year. And you can see some new other genetic area information, these multi-analyte assays. In chemistry, looking at different alcohol tests with either breath or other specimens. And just a lot of codes over with the COVID codes, and then again with all our proprietary lab codes, a lot of those 81 codes added, 3 revised codes that I could count, lots of those codes. And again, you'll see more and more with the different companies coming up with new COVID tests as well. In the medicine section, we did get 1 new code in the immunoglobulins. Really nothing new in the vaccines. Just remember, watch for the updated codes. Just added some of the guidelines. Most of the psychiatric, really most of the changes back here are because of the fact that we do have the removal of that level 1 or the 99201 code there. And a little bit in hemodialysis. And I'm just going to quickly go through this so you can kind of see what those changes are, so you can go back and review them later on. And I think that is probably all the time we have for that today. What I want to go in and do is I want to just check quickly and see, because we have about 4 minutes left, I'm going to go and look at the questions and see if anybody has any questions before, and I can go through some more of these as well if anybody has anything. So let me look at the questions very much and see if everything is good. We're a couple of people that had audio problems. I'm sorry there, but it looks like we're doing good. We did have a question. Did the new E&M time-based criteria include the nurse or CMA obtaining history and updating medications? That's a really quite good question. On the office visits, those new E&M time-based criteria do not include the nurse or CMA. It's only the practitioner, which is going to be your physician, your nurse practitioner, or the PA. They do have rules about splitting time. If the nurse practitioner and the doctor are in for part of that, you just can't double dip. But no, you can't just say the patient was here in the room for 30 minutes. You can't count the 30 minutes. It is just the basically the professional there, the practitioner there. Okay. All right. So let me see. It looks like people were having some technical difficulties, but I apologize for that. If we do find that there were a lot of technical difficulties, we can always go back and we can re-record this. Sharon, are you still there? Did you have any technical difficulties hearing me as I was going through?
I am still here, Karen. I did not have any issues. I know a few people did submit some comments that they were having issues. I think it might have been bandwidth related.
Okay.
But yes,
Right,
we will be sending out, we are recording this, so people will be able to access the recording on demand if they felt like they missed any pieces of it.
Great, awesome there. So here are your resources that I use to gather this information. Of course, the professional edition, which I was giving you page numbers today, in the book that I also mentioned. And then also this is where you can get code updates from the AMA. You can just go into specifically the AMA-ASSN.org, and then you can see there specifically, go to that information, and then you'll get on their mailing list, and they'll send you if there's any changes codes that have come out. Again, we keep getting tons of codes that are being released there now for the COVID, and we'll continue to see those as well. So hopefully those will help you. Okay, I think we are at the end of our time for today. I'm going to check one more time and see if there's any other questions. And I don't see any other questions there. And again, I always try to put too much information into this 1 hour presentation, but that's just because I want you to have all of the changes so you can go back and review those. And hopefully I was able to give you those changes that are most pertinent, the biggest changes for this year. And then you've got a little bit of time that you can go back and review those and look at what would actually impact you in your practice or your facility. And then you can take that information and go back and educate your clinicians. This is if you are, again, Sharon said that basically you that are on live right now do not have to go out to this information, but if you are watching this from the recorded, Sharon, do you want to say anything more about the AHIMA CE credit for today?
Sure. I did just want to mention again that an email will be coming out first thing tomorrow morning that will contain a link to the recording. It will also have a copy of the handouts. The link that's on these slides is not live yet. It will go live once we end the webinar, so you won't be able to access the evaluation quite yet, but it should be live within a few moments if you do want to get ahead of things and print out your certificate that way.
Well, thank you, everyone. We really appreciate your joining us today, and we hope you have a wonderful rest of your day and happy holidays coming up. Thank you, and thanks, Sharon, for all your help.
Thanks, Karen. Thanks, everyone. Bye-bye.